では次のセッション
We'd like to start the next session. What can Japan contribute to promoting UHC globally? In this session, regarding Japan's medical system, we will be looking at the results of analysis. The overall director of this program, Professor Naoki Ikegami, Professor and Chair of Keio School of Medicine, will be reporting. Thank you very much for your kind introduction. Let me talk about Japan.
次はどこです。ありがとうございます。
Thank you. On achievement of UHC, universal population coverage, where all of the citizens are enrolled in insurance. That's what UHC is. But low out-of-pocket expenditure, 14.4% of total health expenditure, according in the OECD. Co-payment is basically 30%, but for elders, it's generally 10% for 90% of the elderly. And when the monthly co-payment amount exceeds the ceiling, the rate is reduced to 1%. So the out-of-pocket expenditure of the patient is very low. It's public insurance provides a safe and effective service. All of the pharmaceuticals are provided. Ratio of this to GDP is relatively low at 9.6%. Over 25% are over 65. So the percentage is low when we consider that. And I personally, in relation to this project, have visited various countries. And in all of the countries that I visited, basically the UK medical service and U.S. Medical services is what they have been influenced by. And so I think we can provide an alternative on the part of Japan. Private sector to be incorporated in UHC to be nurtured. And as to achieving population coverage, in 1927, initially there was a law mainly for manual laborers and miners. And gradually, presently, we have for the medium and small-sized enterprises, NHIA, National Health Insurance Association, and Society Managed Health Insurance and Mutual Aid Associations. As for residence-based health insurance, 1938 saw the enactment of the Citizens' Health Insurance Law. Initially, it was voluntary, but it became mandatory in 1959. In 1961, the all-enrolled insurance was achieved. So the municipalities and the prefectures, the total number of this is 1,800. So we have 1,800 programs. As for motive for expansion, before World War II, it was super partisan, and after the war, to build a welfare state was the objective. Before it was to build a warfare state. It wasn't all of a sudden that we saw all enrolled insurance. During the war, 70% were covered, and gradually, in particular, before the war, there was a rapid expansion in coverage, and after the war, with the reconstruction, we saw further expansion. In 1961, it was when the last municipality provided coverage for its citizens. And there's a difference between UHC and all enrolled insurance. We hope that you will understand this. All enrolled insurance is such that in 1961, all were enrolled in public insurance, but UHC was not fully achieved. And the reason for this is because that other than employment-based insurance, co-payment was 50%. If 1 million yen was medical expenditure, 500,000 would have to be borne by the individual. That was the state in 1961. And as for extra payment, that is insurance covered proportion, and self-payment has been provided. And that system was not completed then. Extra payment system wasn't completed. So you're insured, but if you go to the hospital, you may be charged more than what you expected, and there was a danger that you'd be reduced to poverty. In 1973, there was a cap so that on the co-payment. And 1983, the special the scope of extra payment was rigorously restricted. And through these two systems, finally, we were able to achieve UHC. So to be able to enroll in insurance, to be able to be enrolled in insurance, and the achievement of UHC are two totally different things. On UHC, there are still challenges. There are over 3,000 insurers, and the premium rate differs. We say public insurance, but the insurance principle is applied. If the insuree's income is low, the insurance premium ratio to income is very high. So depending on the insurer, their differences are threefold. It's very regressive, almost highly regressive, more so than the tax system. If we are to confine this to within threefold, 3 times, that is allocation from tax, from national insurance or the elderly, 90% of the benefit with regard to national health insurance, 16.4% is covered by tax. And the insurer takes fair distribution of the medical expenses. With social changes, there have been differences in financial standing of the insurer, and there was a need to mitigate. And as a result, the fiscal burden of the government went up, and contributions from the employment-based plans went up. And that is the source of funds. You have the employer, employee, and others. There are 3 layers, and the tax burden differs. The red portion is the tax burden, and here you have the age 75 and over. Half of this is tax. It's the same as the national insurance, but 40%, over 75% and over, all of the citizens in Japan share the burden for those aged 75 and over. That's with regard to this 40%. Moving on to the next theme, and that is payment to the medical institutions. I'd like to talk about the fee schedule. With regard to challenges facing payment system, fee for service provides you have income for the services that you've provided. So that provides incentives, but it leads to cost escalation. As regards to global budgets, so there is no incentive. And so even if institutions did nothing, they would receive income, so they feel they don't need to do anything. And the other point, with regard to public hospitals, there is a budget comprehensive payment. And for private sector institutions, it's a fee for service. And this is seen in many countries. So the medical services tend to go to the private sector, and the disparity is enlarged. Japan's fee schedule has solved both of these problems. Firstly, the institution's payment is based on the fee for services that provides incentive. But on the other hand, the medical expense, the global budget ceiling sets a cap on the expenditure. As to why this is possible, the fee for service is based not only on price, but also on the volume of services and the conditions of billing. And medical services and drugs, pharmaceuticals, there was a sense of balance in trying to implement reform. I'd like to explain this going forward. The Japanese system is such that there are over 3,000 insurers. insurer organizations. And medical institutions are mainly private sector. 80% of hospitals, 95% of clinics are private sector dominated. So if you just look at this, it's identical to the system in the United States. It's identical, but it's still different. And the difference is the fee-for-service system. For patients, insurance provides certain kinds of benefit, and the content is defined. And medical institutions are provided the price and conditions for billing, when and what times rehabilitation can be provided. There's restrictions in terms of this. So the fee-for-service role is, mainly speaking, for the patient and for the medical institutions. For all of the patients, the content of benefit, what insurance provides for, and what should be paid through co-payment is defined. In the case of patients paying co-payment, over 95% is listed on the fee schedule, and that is a target of benefit. And service to the service and to the pharmaceuticals, there's a fixed price. The price is fixed, and the co-payment percentage is the main income. Under 5% would be, for example, extra room charge. As for extra payment, where insurance covers a certain benefit, and what is not listed in the fee schedule, if that would be restricted to extra rooms charge and advanced medical services, where the effectiveness has not been verified. And as to premiums, doctors claiming that a certain amount would be added because the doctor is a good doctor is banned. And with regard to all of the health facilities, prices and conditions of billings are set forth. 95% of the revenues of all providers, and 95% of revenue would be by setting price and controlling of volume and quality of care. And the conditions for billing is restricted so that the volume and quality are both controlled. For example, in the case of rehabilitation therapy, provider must employ 5 or more physiotherapists and meet minimal physical requirements such as a therapy room over 160 square meters, and patients must be within 150 days of onset. These are the conditions. And when these conditions are met, and only when these conditions are met, can billing be done. And as for claims reviews and on-site audits, adherence to these conditions is monitored. So these are regulated revenue. And from this regulated and restricted revenue, the health facility can determine the wages of physicians and nurses and other staff within the revenue regulated. And these documents are as voluminous as telephone directories of the past. It only not determines price, but also determines conditions for billing, and that's why the voluminousness of the documents. One other important thing is that once you create the fee schedule, that's not the only important you should do. It's necessary to keep on revising, and we do that every 2 years. There are 3 stages of revision. The first stage is where the global revision rate is set, and or the total healthcare expenditure is global revision rate multiplied by previous year's expenditure plus an extra portion. The alpha, or the extra portion, is non-price factor increases, and we call this natural increases. With advances in technology, and there's a more shift to expensive services from CT to MRI, or with aging, there's increase in volume. In the past 3 years, based on the track record, 2 to 3% per year is the increase which we assume for this regulation. The second stage is setting the revision rate for each item, and that is where for all of the medical treatments, the price of each item, the ups and downs, multiplied by volume of services, it has to fit within the first step, that is the global revision rate. And South Korea and Taiwan have similar systems to Japan, but they do not have this individual revision rate for each item. And third step is revising the conditions of billing, where we adjust the volume. And I will Professor Campbell will go into this in detail later. The overall revision rate is determined by the ministerial level, and the price for each of the services and pharmaceuticals are determined, and then thirdly, revising the conditions of billing. The second step and third step is such that the MLHW and the regional entities determine this together, and what this makes this revision possible is this approach taken by the organization. And next on changes of medical expenses. In the United States, the medical expenditure just keeps going up. In the case of Japan, MRI price in 2002, when we revised the fee schedule, was reduced 30%. And even with the increase in volume, in terms of medical expenditure, medical costs, it has been alleviated, as you can see. And so initially, when prices are set, the price was set low at 2 times that of CT. And why is the price low? But why do we have a lot of MRIs deployed in institutions? The institutes are ready to install MRIs at the suffer even at a loss. And the providers, the suppliers of these MRIs gave large discounts. With regard to prices of new drugs, the price is set by comparing the cost to existing drugs. When the efficacy and safety is approved, the product is automatically listed in a fee schedule. And the price is then reduced to reflect the margin between the market and the wholesale price at the time of the fee schedule revision, and which brings about the downward spiral of prices. The new drugs cost 98% is R&D, and therefore, when the patent expires, the price goes down largely. It should go down theoretically 2%, but the present generic promotion is insufficient. And the the price goes down in view of the market price, and this is the reason. The government does a survey regarding the price and volume, and a 2% margin is added onto this to revise the fee schedule price. And based on the revised fee schedule, there is a negotiation between the providers and wholesalers to bring down the price, and that's the mechanism. But this is insufficient. Platinum-containing agents for cancer. If we look at the volume for this and the breakdown between brands and generic, look at Japan and the United States. The red is the generics, the so-called generics, and Japan is very slow in generics replacing brands. In the United States, as soon as the patent expires, people turn completely to generics. And it not only it converted to generics, but in Japan, the generics fee schedule price is high. So to a certain extent, the sales volume may go down, but it tends to remain high. In the United States, once the conversion is made to generics, the price goes down. The fee schedule goes down. So in the United States, the pharmaceuticals price is cheaper. And this has a large bearing on the deployment of doctors. The fee schedule is such that regardless of the price trends of the locale, the fee schedule sets the same fee by receiving the same amount for the same service. Rural hospitals can set higher wages for the physicians and lower wages for the nurses and other staff. And urban hospitals, physicians have lower wages, but they can deliver high-tech care and live in big cities. And nurses and other staff in rural hospitals are willing to work at lower wages because they can live in their own home time. The fee schedule sets relatively high fees for primary care services compared with high-tech care. And that gives incentives for hospital specialists to go into private practice. And when they do so, they cannot access hospital facilities, so they provide primary care. in designated cities. These are in major cities. The physician's income is 164,000. In case of towns, village, and municipal hospitals, 197,000. Private practice clinics, in these, doctors receive 210,000. Registered nurses receive a higher amount in big city municipal hospitals. So this structure is seen only in Japan. On the left-hand side, the physicians, if they look for something interesting to do, their pay becomes lower. But practitioners, they may get to do less of what interests them professionally, but in order to compensate for that, they have increased income. So the fee schedule provides for a very balanced system. Another experience of Japan that we want to share is that initially, we're lenient with regard to qualifications of doctors, and later we got more stringent with regard to licensing of physicians. And after we granted licenses, the government restricted licenses to graduates of university level schools and to those of vocational level schools who have passed licensing examination. And after that, vocational level was abolished and all schools became university level. Government has consistently set for standards for establishing medical schools and control the number of enrollees. So the government gradually raised accreditation standards of vocational level schools. Licensing of the nurses, a two-level system is maintained so that this responds to increases in hospital beds and improving the quality of care, and provides flexible career path from LPNs to RNs. And what we can share with regard to the present system, UHC public insurance expanded has been achieved by expanding SHI, but disparities in premium rates across programs have continued to exist. And it should have been integrated earlier, as Mr. Takemi has mentioned. Fee schedule regulations has restrict extra billing and prohibit balance billing, and auditing compliance to conditions has contained costs and maintained equity. We have maintained the vitality of the private sector. And physicians, monetary and non-monetary wards, practice as a specialist have balanced each other. Income of specialists in big city hospitals were smaller than income of physicians in rural clinics. And this is a feature only seen in Japan. So this is the experience of Japan, and by sharing this with the world, we believe and hope that we can contribute to the promotion of UHC throughout the world. Thank you very much for your kind attention.
Thank you very much. Please move to your seat right here. Next speaker is a member of the Japan research team, Tokyo University Institute of Gerontology, Professor John Creighton Campbell, who is the next speaker.
So that Sweet will not be too lonely, I'm going to talk in English. And I'm going to talk about politics. It's actually not so much political economy as we were using earlier. It's more just plain politics, meaning when people with different interests, different goals, and each with a certain amount of power contend with each other, and results follow from that. And there are various levels of politics that are important in understanding the development of Japanese health politics. I suppose the most important is the same point that Michael Reich was emphasizing for the whole world, to make the same point in Japan. The big changes that we've seen in Japanese health policy have come as the result of politics, and indeed of party politics having to do with elections. In 1959, Kaihoken, health insurance for all, that established the basics of universal health care in Japan, was clearly the result of a political agenda being pursued by the Liberal Democratic Party in its sharp contention with the Japan Socialist Party at the time. And again, the big expansions in health benefits of various sorts that occurred around in the early 1970s were very much the result of a social movement for better health care, particularly for older people, that was being pursued in local governments in Japan, and the Liberal Democratic Party had to respond to that with major benefit improvements. Another example is in the early 1980s, after the Liberal Democratic Party had won a big electoral victory in 1980 and had some more space to operate, had more freedom from opposition party criticism, we saw a shift in healthcare and in other fields to a more austerity-based politics. We think of Ronald Reagan and Margaret Thatcher and Yasuhiro Nakasone, who started the emphasis in Japanese health policy not on expanding benefits, but on controlling expenditures. So that kind of big party politics, big, large-scale politics up at this level have been the driving force in the important developments in Japanese health policy. But at the micro level, we've also seen a lot of jostling among competitors for money and control of different smaller angles within the Central Medical Council of health policy outcomes. What I'm mostly going to talk about is the politics of total spending. A major achievement in Japan, even though society had been aging so rapidly, we know that the growth rate of health expenditures has been relatively low. Every 2 years, as Professor Ikegami mentioned, the government decides how much the nation's going to spend on health care. They don't actually decide the amount, they decide the growth rate of the fee schedule, of the fees paid for medical care items. Professor Ikegami said that ministers of finance and health, together with top bureaucrats, set the rate. That's a dry way to put it, but actually there's a political process over weeks and months with lots of noise and lots of public attention that sets this rate. There are 3 decisions that come from this process, and I'll show them to you briefly. The first is, how much is the growth rate of pharmaceuticals going to change? As we can see from this chart, that bottom line shows that this is yearly growth rate of these 4 items. The bottom line is pharmaceutical prices, and we can see that every 2 years, those are driven down by anywhere from 4 to even 8%. And the second one is medical service fees paid to physicians and hospitals for their services, and sometimes they go up and sometimes they go down. That's the red line here. Usually they've been brought up a little bit a year, but sometimes they go down depending on conditions. And I keep doing this wrong. And the third one is the total of those 2, which is the net growth rate of the fee schedule. That's the green one, and as we see, that's mostly been positive, but it has been sharply 2 or 3% below the growth rate has been 2 or 3% below the previous year on several occasions, and that's all the product of this kind of political process. The final line, the blue line, is general medical expenses. That's the growth rate of overall health spending in Japan. As you see, it's related to the decisions we're talking about, although that's not in a one-for-one relationship. Who are the protagonists in this? On one side, we have the people that are pushing for higher healthcare expenditures, which is most of all the Japan Medical Association, and then they're backed up by quite a number of politicians who support them in the majority Liberal Democratic Party, the majority for all but 2010 to 2012 in these years. On the other side, we have the people that want to hold down health expenditures. That is, of course, the Budget Bureau of the Ministry of Finance. And perhaps surprisingly, they are generally in agreement with the Health Insurance Bureau of the Ministry of Health and Welfare. What's interesting about this process is the top levels, the Prime Minister, the big party leaders, even ministers themselves, are not usually directly involved in this process. How do they fight? It's not a matter of people sitting around a table and having a formal negotiation. There are meetings that go on, but more important than the meetings are speeches, leaks to newspaper reporters leading to newspaper stories as the spending side and the control side, fight back and forth. Interestingly, it's not just a political fight because both sides rely on data based on real surveys. So they have real price data and real volume data, and they from the contending sides, and they debate it. In the end, they reach a big dramatic decision in December every 2 years with it looks like a big final negotiation between the Health Ministry and the Finance Ministry. There's a lot of publicity about it. The newspapers make it into like it's a really big deal. Intermediaries have to come in between to help settle this discussion. And then in the end, actually in most years, the amount in question is very, very tiny. And in fact, months before, all the participants know very closely how this is going to come out. So in a sense, it's a lot of noise and a lot of drama that does not signify very much. On the other hand, underneath that is a real political process. There have been some unusual years. That's the normal process. But sometimes the environment has been different. In our period we looked at, in 3 years, that was the case. The big austerity budget under Prime Minister Hashimoto in 1998 that affected the whole government, and then Koizumi becoming very much involved in the process in 2002 to push down prices and spending, and then in 2010 in the opposite direction when the Democratic Party came into power under the slogan of the downfall of the healthcare system, saying we needed to spend more money and more money on hospitals, and they had a big event. In those cases, the higher level people do get involved, and they do have an effect on how the healthcare spending works out. Does the system work very well? Well, as we saw on the chart, it does not control health care spending in a very direct sense. The health care spending on the top has gone up and gone down, but we do notice that in the time when they were pushing austerity, it kept the growth rate lower, and then at the time when the Democratic Party was pushing for more spending, it did bring it up again a bit. So it has been responsive. But in the end, I would say that the effects of it have been, on the positive side, this process controls prices, and controlling prices is the way to control healthcare systems. A second aspect that's very important is that the process brings together technocrats, expert bureaucrats on the one hand, and politicians on the other, and they have to interact to make this work. Good data is used in the process, but it's not a data-determined process in any sense. As a political scientist, I call that a plus. The key, I think, is that the process is very complicated, and it's repeated every 2 years. It's a routine that everyone gets into, and the participants almost have to fit into the underlying political logic of this as caused by the process itself. In the end, it means that big decisions don't happen in here. We don't get big changes. The Japanese basis of the Japanese healthcare system has changed very, very little, particularly compared to the United States or compared to the UK or the Netherlands, which are frequently adapting their healthcare systems. It doesn't happen in Japan. Again, for me, that's more of a good thing than a bad thing. On the other hand, when political conditions change, it has been possible for the process to reflect those changes, to become more austere, or in some cases to redirect resources from one area to another. So in that sense, and because it has been so successful in holding down healthcare expenditures, it seems to me that it has worked very well for Japan. Thank you very much.
Thank you very much, Professor Campbell. The next person who will be presenting is Director of Institute for Health, Economics and Policy, Mr. Shuzo Nishimura. So over to you, please. I'm from the Institute for Health, Economics and Policies. My name is Nishimura. My report will look at the demand side. Who has been bearing the medical cost? That is what I will be explaining, very simply put. In continuation of what has been discussed before, the challenges after UHC has been realized, and as Mr. Ikegami has explained, UHC and all enrolled insurance, where everybody is enrolled in insurance, are two different things. He has pointed this out. And one of the important points is that we have various disparities in terms of insurance premiums borne, but we continue to develop. And to look at this, a complex factor is that we need to look at the insurance premium, but also the tax comes into play, and that's the source of financing, and that's why it's very complex. And I'd like to explain about that. Very briefly, after all enrolled insurance has been established, looking at these changes in the economy and how that impacted health and health insurance, as mentioned before, the economic growth rate in the three periods has seen a large difference. Up until 1970, the economic growth rate was 9.6%. From 1970 to 1990, and from 90 to 89, we had the economic bubble. And from 1970 to 1990, the average growth rate was 4.5%. And after 1990, the annual average growth rate was 1.0%. It's very important to look at what approaches were taken in each of these periods. To state my conclusion first, as Mr. Takemi mentioned, right before we entered 1990, the economy was very favorable. And so at this time, to make for equity in burden sharing, this issue and fiscal deficits, to expand that in terms of medical expenditure. Perhaps we could have taken measures to prevent both of these from happening. And that is the argument that I am presenting. Of course, other than that, as an important point, as shown in the next diagram, we are seeing an aging of the population after 1990. Not only the economic growth rate, but the per capita income of workers has gone down. And along with this, tax revenue decreased and the fiscal deficit ballooned. And another important point, after that, the income disparity became larger. The aging issue needs no explanation. I will just simply show this graph. But very simply put, the point of my report is that we knew this in advance. Why is it that we couldn't coordinate, make adjustments earlier? Did we make sufficient adjustments? That's the point. As mentioned by some of the previous speakers, Japan will see an increasing tendency toward aging. So how to cope with this is an important point. And mention has been made of this earlier. We have 3,000 insurers. It's the employees and families and self-employed and retirees. The benefits are the same. Slightly different for the senior citizens, but the base benefits are pretty much the same. But it's the co-payment that's very different, and the age composition and the income composition is very different. And there's a lot of disparity between the national health insurance and through tax-sourced subsidies, we have tried to somehow adjust and coordinate. As Mr. Ikegami explained, there are two systems. There is the employee insurance and self-employed persons insurance, and they both bear part of the burden for the senior citizens and the employers. And among the self-employed, because the financial burden is larger, tough, the government provides subsidies. With the aging of the population, naturally, medical expenditure goes up, and so the two systems shows the difference in age composition. First, with increased aging, at the very top, we see that there is a lot of fiscal subsidy as that has increased. And within the institution and system, there are different mechanisms, and coordination between the mechanisms and systems is something that we need to look at. And it's a bit complex, but to briefly explain, this is the equation that can be used to explain very briefly. Between the different systems and programs, there's a lot of coordination, and as a result of this coordination, the covariance or the disparity, CV stands for covariance, the disparity goes down, but considerably. But the original income disparity cannot be fully compensated for and adjusted. And what's difficult here is that when high medical costs are involved, that's because of aging of the population. But that doesn't mean we're channeling that much subsidies. That is, if individuals make efforts to maintain their health, the cost would go down. The effort has to come into play so that premiums and incomes are such that the higher the income, the lower the premium. That is the mechanism. And within the employee insurance, there's a lot of fiscal disparities. To state my conclusion, the difference in premium burden sharing is having an impact on national insurance, and the disparity has expanded. That's because of a growth rate decline in 1990 and with the aging of the population. And lastly, I have and this is the content of our report. I have added just one comment to this. I'm an economist, so I think that the system should be unified and integrated into a single system to think about how to make for more equity in distribution. As I have been listening since this morning, within different systems, each should try to come up with its own system for equity. And for stages 1 and 2, I believe that's has more of a potential in terms of contribution. This is not in the report, but this is one point I wish to add. Thank you very much. The next presenter is Professor Swift, advisor to the Health Minister on Global Health Thailand. What lessons from Japan are relevant for other countries, Thai perspectives? We'd like to have him share his thoughts on this. Thank you.
Good afternoon.
Japanese word I want to say now. It is always an intellectual enlightenment for me to listen to and to talk to senior Japanese scholars like Professor Ikegami, including Professor Campbell Nishimura on my right side, and especially my old friend, Michael Reich. One of my senior mentors used to tell me that one of the best things in life is to meet a good and able teacher, because he or she will simplify complex issues for you to build up your intellectual capital easily, as compared to those lousy teachers who make simple things complex and don't understand. The name that I mentioned, they are my real good teacher. For the Thailand Universal Health Coverage, we are very proud of that. Why? Not because it is successful, but it may be the only one thing or few things in Thailand, Thailand's development achievement, that we are at par with countries like Japan, and even move above countries like the US. This is extraordinary for us, so we are happy with that. We involve actively in this Japan World Bank partnership program. During the process, I asked all my colleagues who are involved, please tell me one most important issue that we have learned from this program. So they sent many inputs. I try to summarize into 5 most important points. First, before we learn from Japan, we learn from so many big developed countries. We understand something. But learning from Japan, extensive experience, tell us that we must not go with any model. Each country will have to develop based on its long history of social and economic evolution. Japan has its own uniqueness in terms of social and economic evolution. I used to be here for 3 months at the Suzuka Circuit Hotel in Suzuka Circuit City back in early 1990. Very interesting time in my life. Not to learn any specific thing. They brought me here to learn about Japan and understand the Japanese people. Japan has a unique system based mainly on its large entrepreneurial private provider. Its financial protection is also based on more than 3,000 funds harmonized in one system. In Thailand, we have only 3 funds, but 3 different systems. We are moving to harmonize, learning from Japan. We also learned that the sustainability of the universal health coverage, we must make it belong to the people and participated by strong and participatory governance systems, and not to put it under mere state governance structure or market force. The case of Obamacare Act and the difficulties of Japanese reform, as mentioned by Professor Ikegami, are a real good example. The second issue that we learn is that private sector is not always bad. We learn from other capitalist countries that don't go with private sector providers, don't go with fee for service. The Japanese system surprised us, and we learned that majority or almost all Japanese USC system are served by private providers. But they are almost all entrepreneurial, family-based private providers. As compared to Thailand, we have many big investors who put private hospitals into stock market, and they become profit-driven providers rather than public spirit, committed entrepreneurial providers. So if we are going to move with the private sector, we have to be able to moderate and regulate them. Third, the fee-for-service payment system is also not always bad. We learned the meticulous Japanese system of fixed fee schedule, and we are trying to apply. Actually, we already applied some to a limited scale to learn more and more. We know that it is a strong case of political economy that we have to be very careful. 4, there is no need to have only highly educated health professionals to deliver the services, no matter how high the social and economic development of the country. We learned this lesson a bit too late. We abolished all the below bachelor degree professional education since 15 years ago. So now we have very few or no private or surgeons. We only have captains. Everyone wants to be a captain, which stay at the bench rather than at the bedside. So I'm sorry that we learned a bit too late. I know that you are fighting here to maintain the licensed practical nurse and other below bachelor degree. Please continue to do that. Don't abolish them. They are very valuable. Last lesson that we learned. As we also meet the challenge of long-term care and huge possible financial burden, we learned from the 2 professors over there. They came to Thailand and they convinced us that don't go with institutional-based care. Don't start by paying institutional-based care. So what we are moving here, led by Dr. Samrit, who is also in this room, the Deputy Secretary General of the National Health Security Office, we will move to pay only for family and community-based care, focus on health promotion and disease prevention. We want to make every Thai elderly healthy until the last day of their life and drop dead. I'm sure that everyone in this room agree with me. Finally, I would like to sincerely thank this movement. It's very valuable. I would like to commend all the leaders, especially my big brother here, Honorable Senator Takemi, and all the Japanese colleagues and the World Bank, who have been so sincere and honest and worked tirelessly to share that story and experience and be our real good teacher. I would like to reiterate that it is these sincere and honest commitments that have made our Japanese colleagues our Kalayana our real friends and teachers. We did not see Japanese colleagues behave like other foreign consultants or experts who move into developing countries just to throw some intellectual garbages and get their bite of money. So I sincerely thank all of you again, and I'm sure that with this strong spiritual commitment, trust-based spiritual commitment, the next phase of Japan's commitment, including chairing the G8 in 2016, will ensure the future successful and sustainable development of universal health coverage among developing countries. I thank you.
Thank you very much. We'd now like to turn to the commentators. Could we please have them up on stage? We have a Professor of National Graduate Institute for Policy Studies, Professor Kenji Shimazaki, Deputy Director Office for Healthcare and Medical Strategy Cabinet Office, Mr. Koji Fujimoto, Director General Bureau of International Medical Cooperation National Center for Global Health and Medicine, Mr. Osamu Utsunomiya, and Mr. Toshiro Kumakawa, Director, Department of Health and Welfare Services, National Institute of Public Health, Japan. We'd like to hand over the microphone to Professor Ikegami to moderate the session. We'd like to ask for comments straight away, starting with Professor Shimazaki, please. I'm from the National Graduate Institute for Policy Studies. My name is Kenji Shimazaki. I do research and I teach medical policy studies, but I was an administrative official involved in the practical matters of planning and exercise of medical policy. So I'd like to speak on that in that capacity. Japan's UHC is based on social insurance system. And to state my conclusion first, for the developing countries, Of course, there are different levels of development that these developing countries are at, but to introduce a UHC a la Japanese style is not an easy thing to do. That is my conclusion. And the reason can be divided into 4 major categories. Firstly, the difficulty of managing the insured. Most difficult is self-employed farmers and the workers, the informal sector. That is, with regard to employees, based on the employment relationship, the insurance arrangements are made. But when it comes to the informal sector, how do you manage the insured? You have to manage based on their address. That's the only means possible. In our country, the national health insurance system, the original model was created in 1938. And since then, we had a system of managing addresses based on census register. But in the developing countries, there is no mechanism in place to appropriately manage addresses. There are not a few cases in which this is the case. And secondly, the difficulty of assessment and collection of insurance premiums. Unlike private sector insurance, the social insurance must cover those who have low ability to cover and pay for premiums. And so you have to think about the principle of ability to pay or premiums which are proportional to income. And what becomes an issue here is to properly grasp the income of the informal sector. As you know, in Japan, we have this issue as well. We cannot grasp with 100% accuracy the income of the informal sector. But we have a tax levy system which taxes based on flow of income, such as income tax and residential tax. So the national health insurance premium is based on the income which is disclosed under the tax system. And developing countries have asset taxation, such as automobiles, but there are very few countries that appropriately assess and tax based on the flow of income, such as income tax, for example. And thirdly, the delay in provision of medical services. If sufficient services cannot be provided, the UHC will be only a UHC in name. So the remote areas, there are great differences between medical service in the rural sectors and in the major cities. In some of the remote areas, primary care cannot be sufficiently provided. And fourthly, universal health coverage. In order to make this substantive, economic growth is essential. Professor Ikegami pointed out that in Japan, in 1961, we materialized an insurance where all citizens are enrolled, but the percentage of expenditures covered was 50% for those employees. By 1973, we increased the benefit coverage to 70%, and we introduced the high-cost illness insurance. And this was possible because, fortunately, since 1955 until 1973, when the oil crisis occurred, we had an unprecedented high economic growth. And on the developing countries, on the side of the developing countries, many are entrapped in the middle income trap, or some countries have the risk of being entrapped in the middle income trap. So I talked about the 4 impediments to introduction of UHC a la Japanese style. But based on our experience, let me talk about 2 important points. First of all, the importance of practical operations processing. UHC is a very complex system. In designing the system, people tend to underestimate the practical operations. But if a part of the practical operations experiences a hitch, that affects the entire system. For example, if the social insurance system is adopted, you have to manage the insured and you have to collect premiums properly. Otherwise, the whole system will not stand. And with regard to fee schedule, it's a very important system. But the fee schedule system in Japan is very complex. And to transplant this directly to the developing countries would not lead to success. I do not recommend this. In any case, the including the administrative and fiscal system and infrastructure with regard to UHC practical operations. There's a need to understand how that was made possible here in Japan and through what process. The other is the medical service provision. In the case the UK system is adopted, this is also a very important system. This is when we moved to the system of universal enrollment. We came up against this problem. We had to there has been a lot of grassroots movement in the rural areas, and this would be very helpful to the developing countries. And the appropriate nurturing and the distribution of doctors is very important. In developing countries, doctors are reluctant to go to remote areas, more so than in Japan. When the pay is very low, they have to look to part-time work. But in remote areas, there's very few opportunities for doctors to engage in part-time work other than their medical their daytime job. If we in Japan we balance out the monetary remuneration and non-monetary remuneration, and it's well balanced. It's very interesting. I have not had enough time to explain my position. There may have been parts difficult to understand, but I'd like to clarify that during the Q&A. Thank you very much.
では続いて藤本様よろしく。
Next, I'd like to call upon Mr. Fujimoto.
内閣官
Thank you very much. I am Fujimoto from Cabinet Office. At the government, the health strategy is something that I look after, so I am doing on strategy healthcare. There are several pillars in the strategy. How do we develop the healthcare sector? That is the fundamental perspective. Of course, we have to regard that in the international context. We have to find ways of developing our strategy in conjunction with the international context. I'd like to talk about that aspect. The previously speakers have spoken the Japanese universal health coverage, the process to attain that. That process was explained by various speakers, which was very convincing. Now, in the case of Japanese UHC, the process to attain that happened during the time of high economic growth period. Another point, at that time, Japan was an island nation, insular nation, and therefore, a little rich people would not go abroad to receive medical treatment. But looking at the emerging countries, the economic development is happening, and certainly the development stages would take time. So there would be certain disparities amongst the recipients. So well-to-do people or nouveau riche would find a better quality medical service, and they go abroad to receive that. It may be only a part of the population, but that once there is a trend of that for the purpose of UHC, the most basic support would not have the economic incentives. And then there is an economic leak beginning from the foundation of the society. I think that is going to be a major challenge. So in that context, UHC, we consider it's a pyramid. The base of the pyramid is the foundation. And then from the prenatal medicine to various medical activities. When there are certain activities, the well-to-do people would require certain medical services. That has to be also attained within that country if USC is there. With that weight in the pyramid can be solidly created. So considering UHC, that country is beginning to develop, of course. Then you have some rich people, then you have to consider how these people will remain within the medical system of the country so that there is the virtuous cycle of developing all together in the medical service sector. Another point, which is good, the progress of IT. Because of that development, the Japanese fee schedule process used to be analog in the past. Every decision was in an analog way, so the practical ability was very high. But with the advancement of IT, what is happening in the medical situation? The digitally, the information is possible. Then real-time processing is possible. What is the inventory? What level? Where the treatment is conducted, and so forth. Things will be simplified. The creation of the system would be enormous, but once the system is created digitally, it would be possible. And remote telemedicine is also another possibility. So Japan has a UHC. We have come through difficult times, but technically there are different opportunities available in developing countries. It's not only like a fixed telephones network you want to develop, but you want to have a mobile ability in creating a new kind of system. That is another possibility open to the developing countries. The third element, nutrition-wise, with the progress of technology, or the functional food is available. So the question is how best you can utilize functional food. So the together with the advancement of the technology and the time, not only the esoteric, sophisticated levels, but the very simple things are available too. So in a hybrid way, you can combine those things available in the recent times. So Japan should render cooperation together with you so that we can attain the overall goal of UHC. Thank you very much.
Thank you very much. Next, Mr. Utsunomiya, over to you. Thank you. I'm Director General of the Bureau of International Medical Cooperation. That's where I do my work. And as some of you may know, up until July, I was in the insurance and medical department of MHLW. And so I was responsible for a fee schedule. And so that is why perhaps I was called upon to speak. So I have been engaged in this cut and paste work in the medical and insurance department. So let me talk about some things based on my experience. UHC. Before we talk about this, the overall medical expenditure and the revision and the process, there was a talk concerning this subject, but before the revision and the revision rate was the Central Social Insurance Medical Consultation Association had decided this. The paying side and the fee schedule side and public interest individuals set this, but there was no room for administration to enter. But since 2006, the revision rate came to be decided by the cabinet, and when this happened, the fiscal authorities and MHLW prior adjustment started. But the revision this time and 2012 revision, I was in the nursing fee schedule and the medical fee schedule, and both revisions were conducted at the same time. And when we look at the revision process, at least with regard to the last two revisions, previous beyond ironing out by the government agencies, there was a lot of political power which came into play. It was, you can say that the political power was the largest factor which was the determinant. And if we look at the prices and the billing conditions, in the past, the revision rate was the extent of influence. But even with regard to the content of the revision, there's a lot of comments and input from the politicians. So things are changing little by little. And Professor Ikegami talked about the fee-for-service and the merits and demerits of the fee-for-service system. And he's most knowledgeable about this, but a fee-for-service is the base. But since 10 years ago, a comprehensive pricing system has been introduced. But before that, with regard to medical system, especially remuneration system, to drastically reform this was a discussion which took place. So based on that, there's a medical system called DPC, and the DPC promoted a more comprehensive approach. But 10 years from then, finally it's been 10 years, things are gradually changing again. Unlike the United States, there are no abrupt changes, as some has remarked, and that is quite right. In our country, insurance system is such that the change is gradual. Compared to 10 years ago, the change has been considerable, and so it's an evolution process. DPC is such that IT has progressed to a great degree, and most of what has been mentioned by the previous speaker is now visible as data. And so these are the changes which have taken place as an evolution, and that's the kind of system the Japanese system is. So if you try to introduce this all of a sudden into the developing countries, I think that's not possible. But we spent many years doing this process. So what do the developing countries aim for? In the case of the Japanese insurance system, the Japanese can feel very comfortable about becoming sick. They won't go bankrupt if they become sick or if they're injured. And in addition to that, they're always pursuing equity and fairness. Perhaps this is unique to Japan. If a patient becomes ill in Hokkaido and Okinawa, they're treated differently. That's strange. Or if you're rich or if you're poor, if you're treated differently, that's strange. So we're very particular about equity, and that's not only about between patients or between insurers or between generations. We're always seeking equity about different things, and we are looking at things from that perspective, and we have a very demanding, we're quite demanding about this, and that is our history. And with regard to countries that are newly introducing UHC, to what extent are they willing to pursue equity, and what kind of incentives are there, and what is the present situation? To what extent do they want to introduce our system? You need to think about that. And lastly, because this is an international medical center, I'd like to talk about that as well, that I presently work in. International cooperation has been started over 30 years ago at the Bureau of International Medical Cooperation. And I'm only a newcomer, but the staff who has stayed in this bureau before me has accumulated a lot of know-how. The content and nature of international medical cooperation has changed. In the past, JICA would ask for hospital assistance or clinical assistance. That accounted for the most part. But gradually, we're looking more toward the regional assessment or administration assistance, looking more toward public health. And at the International Medical Cooperation at the National Center of Global Health and Medicine, this is the kind of change in assistance we are changing. So the health medical strategy or international medicine and deployment thereof, we're always thinking about what kind of assistance we want to give. Within the center, a global medical strategy has been crafted in September. And this is in tandem with national policies, so that we can take on part of the national policy. We have decided to make efforts. We solicit your continued cooperation. Thank you very much.
ありがとうございました。続いて。
Thank you very much. I'd like to turn to Mr. Kumakawa. Thank you. I am the Director, Department of Health and Welfare Service, National Institute of Public Health. Our job is nurturing human resources, especially the future leader training and nurturing in the field of health and welfare. So I'd like to explain a little bit of the background. Maybe former name is known to you better. National Institute of Public Health, that was the name in the earlier times. And together with that, we had But in 2014, two institutes joined, and then we have the two welfare of public health and welfare services. So that's the background of our organization. So regarding a UHC and the Japanese possible contribution, it is something that I would like to talk about with the background of training human resources. The first point, in the area of international medicine, we are cooperating, and to developing countries or low and middle income countries, we receive trainees. And we hear their needs. We ask them what kind of requirements they would have. There is a long history. And of course, there are various professional sectors. We provide technical training to relevant sectors. But in relation to UHC, we have training programs. The Japanese process of introducing UHC, that is something that we teach. And also in terms of medical insurance, we have the public health stations as well as public health nurses that we are very proud of. So we teach them about them. Japanese system is a well-balanced system. We have the fee-for-service and the fee schedule, and we have this insurance. So there is a good balance between the two. Recently, non-communicable diseases, that's lifestyle-related diseases, countermeasures are needed. And also the leadership nurturing is required in that particular field, in the field of public health. That is the area where requirements are rather strong. In the recent past, I see a big change. What I said is that the themes are more or less independent of each other, and we can provide separate trainings. But in the recent past, the trainees participate in various programs, and their interest is not regarding the single parts of the medical system, but they want to have the improved quality of the system as a whole of insurance and medical health care. So they are very much interested in the comprehensive management of the system as a whole. Because of that strong interest, the incumbent skills that we have would not be good enough to respond to their needs. So the MHLW's the International Affairs Division, as well as the JICA and the National Institute of Public Health professionals are coordinated so that we go beyond the borders of organizations. We are trying to have an integrated system management training in a multidisciplinary way. So last year we have started this training. So this year we are commencing the second year of the training. So the aging is UHC, and aging is very much discussed. But the comprehensive system solution is the point of interest. So I can't talk about every single project, but concretely, strategic management framework is utilized so that we can identify issues, we can determine the priorities, we formulate plans, implementation. So we are providing training comprising of all those issue areas. The second point I wish to mention is in relation to UHC is how we can share our knowledge, institutional knowledge, with other people in other countries. I think there are three relevant points. The first point is that the Japanese history, we have sorted out information about Japanese history. But compared with other countries, I think we were blessed in our environment through which we created UHC systems. Before and after the war, we developed our economies. We were able to upgrade the social infrastructure. And we came in tandem with that. So we had a mountain of overcoming the communicable disease, and then we have the mountain of non-communicable disease, and now we are faced with the mountain of aging. So we were able to focus and identify single focus in what we do. But looking into the low and middle income countries, those three mountains had to be climbed and overcome simultaneously. So it's a very tall order to come up with a solution to these three mountains. So we have gradually climbed the three mountains one after another. So that's our experience. But the current international community has the challenges of three mountains simultaneously. So our knowledge and our experience is something that other countries are dying to learn from. The ICT utilization was mentioned by Mr. Fujimoto. So in real time, we can convey our experience to other countries. The second one is the comprehensive management system that is of the interest. Then human resources development focusing in single area is not good enough. As Mr. Takemi said, at the country level or on a regional level or on community level, at least in these three fields, the vision is formed, and then a policy is formulated, the ability to do that, and then the strategy can be implemented by manager class people. Everything has to be put in a package as a training program. Otherwise, we won't be in time to respond to their requirements. The third point is, as Mr. Fujimoto mentioned, we have to include long-term nursing care for the elderly in UHC going forward. Now, the insurance and healthcare are combined, but by 2100, more than 50% of the countries of the world will have more than 21% of the people above the age of 65. It's a super-aged society. Most of the Asian countries will be in the super-aged society. So in the remaining 70 to 80 years, we will have to provide our experience to other countries. So our challenges will be their challenges in 70 to 80 times. So Japanese uniqueness, a Japanese advanced feature should be a sort of focused, so that the medical care and insurance, healthcare insurance can be put in one package to provide to other countries. What is the benefit? What is the advantage of Japan in doing so? I think there are a lot of advantages that we have. In the field of industrial management, there is a concept called reverse engineering, which is pretty good at established. Innovation usually comes from upstream to downstream. That is usually the way the innovation is propagated. Reverse engineering is proving that the opposite direction is possible. So in the developing countries, emerging countries situations, the certain knowledge could be created that could be introduced to the upstream developed countries in exploring new areas. In the pocket, the very small supersonic equipment was tried to be introduced to the rural area in China. And then the experience they gained in that could be reintroduced to the developed countries in a reverse way. That was to cultivate a new area of usage that developed countries never dreamed of because of the experience coming from the developing countries. Therefore, reverse innovation is possible from the notion of UHC. That is what I feel very strongly, which provides a very good advantage to our country. Thank you very much.
それでは終了まで
We have about, or only 10 minutes before the end of the program, so we'd like to entertain questions from the audience. Please raise your hand, and we will bring over the microphone to you. Mr. Kodera, please. JICA Director Kodera speaking. I listened to Professor Ikegami's presentation as to what should be shared among Japan's experiences. And in a very perfect way, he has summarized this. And perhaps I believe that that is the starting point. And then Mr. Shimazaki challenged. And this is something I had been informed of before. It was a somber. It was very sobering. And in terms of age, I'm closer to Mr. Shimazaki than Dr. Ikegami. Professor Shimazaki's, or the people from one generation after Professor Shimazaki, these people think that IT, or Mr. Fujimoto, one generation from Mr. Fujimoto feel that IT will be very helpful. And many things have been mentioned. The maternal baby book, a baby care book can be incorporated into the IT, but this cannot be internalized. And Professor Shimazaki's challenge is that with regard to Mr. Fujimoto's generation's solution, if you pursue his approach, even if there's a will on the part of the developing countries, the issues that Professor Shimazaki raised can be overcome in many respects. In India, there's a large population, so to identify each person and to have this incorporated in IT is something that they're spending a lot of money on, and this has spread to other developing countries as well. And in creating the social safety net, this is very important. So leveraging IT is something that is very much talked about. And my comment is that there's to say that there's a lot of challenges, but it's not all that dismal. That is has been expressed by various persons. They've focused on UHC, but there's a lot of things that Japan can do, and that is my feeling. Thank you. Thank you.
Thank you. Other question or comment? Yes, that person on that side. Thank you very much. My name is Akashi from International Medical Research Center. Thank you very much for your interesting presentations and remarks. Capitalizing on Japanese experience, that was the topic for which a lot of people referred, and one size does not fit all, so Japanese experience cannot be transplanted. Now, in Japan, there are 3,000 insurers. So partly it was included, and then it ended up in becoming 3,000. So if you have a plan beforehand, and by plans, if you include parts to an entire system, with the change of times, you will be able to respond to the changing times, and then Japanese experience could be introduced to the developing countries. That's how I feel about it. So I'd like to solicit panelists' views. Thank you.
I can answer, but Professor Shimazaki? Because it's a very difficult thing to do. The majority of people who are here probably feel that insurance should be integrated, and insurance premium rates should be such that it also should be unified and integrated. I'm sure, I feel that the majority thinks so, but I do not necessarily subscribe to this view. The reason being, perhaps Mr. Nishimoto mentioned this to a certain degree, the grasping of income, to have knowledge about the income that is the employee, and other than employees, the rate to which income is known or grasped is very different, and it's an issue that cannot be resolved. And I've discussed this point many times with Professor Ikegami. And we cannot overcome our differences. So in that regard, taking a different example, South Korea is a case in point. They have one insurer. They have only one insurer, but workers and other than workers are different in the way the premiums are levied. There are 3,000 or so insurers, but when it comes to benefits, in substance, it's identical. With regard to medical remuneration, it's completely unified, and this is a major factor. As regards co-payment, that's a discussion that exists, and a great disparity has to be, if there's a disparity is too large, it has to be rectified. But having said that, I don't believe that this should be dealt with based on income. Thank you.
しかも、じゃあ、
Well, allow me to offer my comment. First of all, in Japan, self-employed, so-called the segment of the people whose income was very difficult to be grasped, but in terms of citizens' health insurance, they occupy about 20%. Now, pension beneficiaries, there are more pensioners than the self-employed. So if you are receiving pension, at least your pension can be grasped by the insurer. So there could be various ways of calculating insurance premium. But this is not a method which is too difficult to be overcome. The employed population will decline going forward. Then employed and non-employed, the two-pillar system is very difficult from sustainability point of view. But on the other hand, in developing countries, if one insurance system is good, then the access to healthcare is so varied in different regions. So if the same system is employed, the one system is employed, then the urban population will benefit, and then the rural people would have a better, will not be able to have the access to the ability to pay based insurance system. So there will be inequity. So you mentioned the possibility of packaging. Of course, there can be many ways of packaging. But benefits are there, and because there are benefits, insurance is there. If there is no benefit, insurance premium is only collected, well, then it will only add to the reverse progressiveness. So unlike in foreign countries, in the case of Japan, as a matter of principle, it's like branching out from elementary school. In remote areas, you establish one public health clinic. So that was the method we followed. So if that was the method, then more equal and fair access to healthcare is a possibility. But if that access is very difficult, only the burden is to be equalized. I think system-wise, it's very difficult. Sorry. Time is in short supply. One question or comment we can entertain?
Again, WHO. Two comments, but then maybe a part of a question. On equity, we've done some work with Professor Kondo at Chiba University, and the power of the data of seeing the Japan Gerontological Evaluation Survey starts to show some inequities emerging when it's combined with the GIS system. So when you map it out, it becomes a very useful tool to start to understand where the system needs to respond. And this also links to a question about how you use the data for integration of health and social services, and ultimately for the payment and the incentives to drive that integration. Because often it's still very medicalized, but you have to bring in the social system, and there's a different fee schedule that may be part of that. On innovation, just very much agree with the reverse innovation. There's another word in English called frugal innovation, and this is becoming a very important part of the dynamic to make it affordable. But what, again, we've seen again and again is that the coherence of policies in the country, say there's an aging policy, but it's not connected to the medical device policy, which is not connected to the reimbursement or the health technology assessment policy. So in most countries in Asia that we've looked at, that coherence isn't there yet. So it is something that for the future. Thank you.
As moderator, I take the privilege of moderate to respond to just one comment. frugal innovation, if you look at the slide I showed about MRIs and how the fee schedule has reset and decreased the price, that led to the force the manufacturers of MRIs to make it less expensive. So in that sense, that could be regarded as frugal innovation. Well, unless I'm allowed to go beyond the time, I'm afraid that was just the last comment. すみません、もう時間が
Sorry, we can't prolong the time. So we hit exactly 4:50. So in a time like this, in a Japanese way, the moderator will apologize because of the inadequacies and inability of the chair. I apologize for the shortness of time. So I will use that typical Japanese apology to close the session. Thank you very much.
それではパネリストの皆さん Thank you very much. The panelists are asked to step down from the stage.